I am really pleased to welcome Dr. Gary Benson to this meeting. He's based at the Northern Ireland Haemophilia Comprehensive Care Centre in Belfast City Hospital. He runs a subspecialist clinics established to include haemophilia carriers, as well as high-risk obstetrics and outpatient management of VTE, with deep vein thrombosis and PE cases. He has a very interesting title, and I'm looking forward to learning more about this and also having it explained further, but it did make me smile. So I'm really pleased to introduce Dr. Gary Benson to talk about reducing the burden of VTE in Belfast beyond Brexit and the Cumberland sausage. Thank you.
Jill, thank you so much, and thank you to the wider committee for their very kind introduction. The title itself probably came from a slightly low moment shortly after the invitation came to give a talk. I think that at the moment, or certainly at that time, Northern Ireland and Brexit was being discussed very widely on mainstream television, and the bit that made me laugh was the Cumberland sausage shortage that we would have to go through because we couldn't import them due to the Irish sea border. I can admit to never having a Cumberland sausage in my life. I would suspect that if potatoes were to have been an issue, it would have had quite a significant implication to the country. So as Joe said, my name's Gary. I am a haematology consultant. I'm employed with a subspecialist interest in bleeding and clotting, and work through the Northern Ireland Haemophilia Comprehensive Care Centre and the thrombosis unit. And that's based within the Belfast City Hospital and within the Belfast Trust for Northern Ireland. At the start, just as we try to get a bit used to a couple of things as that we settle in, what I want to do is to go through a few things just to try to orientate your own hearing. I appreciate, and I'm quite focused with regards to my accent. And Northern Ireland accents are lovely. So what I thought we'd probably try to do in the first slide is just to go through a couple of words where you can say them inside your head, and then I will say them as I say them, and then hopefully by the end of it, we'll have become a little bit accustomed to it. So this chap here is getting washed. We do this in Northern Ireland regularly too. And you're probably looking at him and thinking that he is having a shower. For me to say that, you can pick up that I sound slightly Americanized. From Northern Ireland, we say that this is a shower. And we do spell it the same. You'll be reassured to know it's the same dictionary. However, we will refer to this as a shower. So he's having a shower. And after his shower, he will get out of his shower and he will use this. So you will all be very well used to using a towel. And again, you can sense the pain that I have in saying the word towel. So we use a towel whenever we get out of our shower. So it's great, particularly if you have a power shower with regards to it. A more favorite word that we often get after a few drinks at a meeting at BSH or something else. So this is where we get our milk from, and this is a cow as opposed to a cow. And the final word that we'll go through will be a little bit like shower. This is obviously a tar, the so-called Eiffel Tower. So just to highlight, I don't believe that I require subtitles. Hopefully you do now. So just for your own information, there's no subtitles during my live talk or indeed during the recorded sessions in order to get orientated. You may, of course, be used to some people from Northern Ireland with regards to listening. So some of our more famous people from NORN, as our lazy accent gives. So we'll have Gloria Hunniford and Dame Mary Peters. Some of our men, Kenneth Branagh, brandishing an award. Bit of a surprise, he comes from Northern Ireland. Out of the Red Dwarf comedy series, Hal comes from Northern Ireland, and interestingly, we frequented the same school. Liam Neeson, perhaps a little bit more famous, but does a great acting career at disguising his accent. And then, of course, we have Jamie Dornan. Now, Jamie Dornan's claim to fame is that he did go to my school, He's obviously talks about me a lot. There are a lot of similarities with Jamie Jordan and myself. You probably appreciate more of those whenever we're actually face to face. And probably that's just because we have the same shoe size. So if we try to think about Northern Ireland and orientating ourselves with it, so we have 5 healthcare trusts. So you can see that the purple is actually the Belfast Trust, which is where I am based and work through. The Belfast Trust will provide the majority of the regional services, the regional specialist services for Northern Ireland, as well as providing healthcare to the Belfast Trust population. In addition to these 5 healthcare trusts, there are an additional 2 trusts, which is the Northern Ireland Blood Transfusion Service, and that is also accompanied with the Northern Ireland Ambulance Service. So within Northern Ireland, the population is 1.8 million. Within Belfast, however, we do like our hospitals, plural. So although we are one trust, we are several hospitals within it. So our first is our inpatient mental health facility, which is the Knockbracken Healthcare Trust. Belfast City Hospital, where I am based and I work, was voted one of the top 10 most ugly buildings in Northern Ireland, described as a streak of diarrhea from the sky, not very kind. It's much nicer inside. Belfast City Hospital, we have the Mater Hospital, again, a medical hospital. We have Musgrave Park Hospital, which is a dedicated elective orthopaedic site, as well as a rheumatology service and an elderly rehabilitation unit. So it's a standalone place. These are not all on the same site. The main acute site, as well as the trauma unit, will be the Royal Victoria Hospital, and the Royal Victoria Hospital will encompass the Children's Hospital regionally, as well as a maternity unit. So whenever we talk about venous thrombosis and monitoring and measuring and diagnosing, you can see that it's quite a spread out geographical site. But also trying to appreciate the fact that each of the sites themselves have their own subspecialty or own specific patterns that we have to work our way through. One thing that very early on in starting service or trying to bring it all together that we noted was really the strength of data. It's very important to measure something, particularly as change is really always on the go in the background. So as far back as my commencement as a consultant in 2008, I had to sort of go through things at that stage, try to see what we perhaps needed to measure, to follow through, and whenever change comes in, can we actually display the fact that change has either been positive or indeed negative. So the majority of the presentation itself will reflect on that data, some of which we have in excess of 10 years of practice, and to see what we have been able to show, what has worked, what hasn't worked, and where we're at. I have no doubt that some of what I may talk about may seem very simple, if not slightly backward, from where many of you are at with regards to your VTE services. But equally, there may well be some things that perhaps I may mention that may be of interest or something that you may wish to start. So one of the very early things were CTPA. So across the main hospital sites, which will be the Mater, the City, the Royal and Musgrave, all inpatients there have access to a CTPA scanner. They don't all have access to a VQ. So early on, with regards to pulmonary emboli, we had made a decision to track all positive CTPAs that were undertaken within the trust. So in general, what this has meant is that on most Mondays, not during this May it's been on Tuesdays, but on most Mondays with a cup of tea and a scone at 8:30 in the morning, I will sit through the radiology systems and trawl the CTPA scans for the previous week. And we'll collate patients that have positive. over the years, additional information has been added to this, such as considering cancer diagnoses and the types of cancer patients are diagnosed with. And indeed, over the last 2 years, adding in where COVID is mentioned on the scan to see if there's any particular association. So we'll go through that data and to see where we're at and what have we learned. We also, through pharmacy, each month get a rolling tally with regards to the prophylactic dosing of low molecular weight heparins across the trust and where they're going, and really just looking at the quantity. It was important very early on, particularly with risk assessment whenever it had come in, was really trying to calm down some of the concerns with regards to cost and prescribing, and equally to provide reassurance that just because you do a risk assessment does not guarantee that a drug has to be prescribed. And actually what we have found over the years that we have done that is there has been no significant change with regards to the prescription of prophylactic low molecular weight heparin within our inpatient units. The prescriptions are also provided through for the complete course at the time of discharge. So our elective orthopedic site at the time of discharging hip and knee surgery patients would also be expected to provide 2 to 4 weeks of low molecular weight heparin. So that's encompassed within that supply. Our VTE nurses over the years, as their numbers have expanded, thankfully, they undertake every month through the acute inpatient sites within the trust. They will review the patient's drug cardexes, within which we have incorporated the VTE National Risk Assessment tool. And we don't have electronic prescribing, so this is a physical and a manual thing, which we feel that has been best managed with the VTE nurses. So they have a rolling ward presence that allows wards to see them, and it allows immediate feedback, and it really allows them to be seen and to highlight the importance of VTE. So there's approximately 1,100 inpatients per month, and will have their cardexes reviewed from inpatient ophthalmology to cancer patients across all sites. And we also, through our outpatient VTE service, where we take predominantly patients diagnosed with DVT, PE and phlebitis from our emergency departments at the Mater Hospital and the Royal Victoria Hospital, we have those patients referred into our outpatient service. And again, we collect the data or the demographics of those patients to help us for the next patient that we're actually going to see. So there's a fair amount that goes in. The one thing, however, is in collecting it is always to make sure that you don't just collect it for yourself or for your team or for nice presentations like this. It's really collected to be shared back with the clinical teams, as well as our trust executive team or management structure, to help to guide us with regards to us going forward. So a little bit of history with regards to our outpatient VTE service. So back in 2008, whenever I had started, we had 2 nurse-led emergency department DVT services. Now, in that year, the trust actually had 3 emergency departments. So the largest emergency department, the Royal Victoria Hospital, did not have this nurse-led service. So there was an inequity of patients. If you had gone to either the City or the Mater Hospital with a query DVT, you were put on a separate pathway, and the nursing team there, 2 based at the City and 1 at the Mater, would have taken you in a sideline, organised your scan and your bloods, and if you weren't a DVT, then you were put back into the ED pathway, and if you were, they then took you aside, anticoagulated you at that stage with warfarin, and then liaised directly with the GP. And the emergency department at the City then was to be temporarily closed, and it's still temporarily closed, although it has now been redeveloped as the day of surgery unit. So the DVT nursing team at that stage, further to our discussions, then were repatriated under the haematology banner. And it doesn't always have to be haematology. Sometimes acute medical services support this type of a pathway just as well as at haematology. But given the fact that the thrombosis unit and the haematology specialists were here within the City Hospital, at that stage, we were very pleased to have the service. Unlike before, we made a slight change in that they took only confirmed cases of then DVT and PE. So the pathway was developed with regard to the diagnoses and continues to be updated in line with the NICE guidance, which applies to Northern Ireland. But unlike before, where it was a query clots, they now only take the definite clots, and it allows their expertise to be more appropriately applied to patients and patient education. Ultimately then, with the one site model, the nursing infrastructure at the Mater Hospital then joined us almost in 2012, so we had a one site service. Because their feeders were always the emergency department, it's largely remained itself through the emergency department where we get it, and it works very well. It keeps literally the flow of patients in the emergency department going. The emergency department doesn't face a reattendance because they then get coded differently. So it is a good patient experience with questionnaires after the change to support that. So ultimately where we're at now is that all confirmed VTE deemed suitable for outpatient management, and there's often a little bit of a discussion with that. We don't necessarily want somebody just removed from the ED just for the sake of it. So those suitable for outpatient management will come to ourselves at the City Hospital outpatients. We are happy to accept all DVT, both upper limb and lower limb. We can take the standardized low risk pulmonary emboli and manage them as outpatients. And we have also taken on board thrombophlebitis. We had originally done that because we'd had a run of cases with pulmonary emboli that was fairly clear to us at that time that had phlebitis and perhaps been a little bit more aggressively managed than a topical cream, that there was the potential that the pulmonary embolism could have been perhaps prevented. So we now take phlebitis as well from the emergency department, which is sometimes it feels like we're sifting for gold in and amongst all of the phlebitis patients. So as an example, where we're currently at with regard to the outpatient referrals only from emergency department that we see, last year we had a total of 435 patients with a rough 50-50 split between men and women. And of those patients, 9% of them were defined as a hospital-acquired thrombosis whenever we looked back at the standard definition. And we'll touch on that a little bit. There clearly is a hole here with regard to the diagnoses of VTE, in that this is just those managed as an outpatient. And again, we'll touch on capturing the inpatient work as well. So some of the demographics then of the patients that we will take through the emergency department and directly to our clinic, seen within 24 and 48 hours. We feel it's a little bit easier if the emergency department simply remains on low molecular weight heparin until the patients transfer across, and the patient's oral anticoagulant, if required, will then be discussed and prescribed by ourselves. So this is the age breakdown of patients. As one would expect with regards to VTE, the skewing of the age range is what one would expect. It's not quite a normal distribution, but certainly the majority of our patients are in middle to late years. I change my perception of middle to late age the older I get, but I'm still middle. Interestingly, whenever we look at the body mass index of the patients that do come across, and I'm not particularly surprised that the vast majority of patients are within the overweight to obese categories, and within our maternity booking procedure, whenever the BMI is calculated, certainly 1 in 4 women now booking at maternity will have a BMI of over 25. And so it's an association, as we all know. So breakdown by diagnosis of what is actually accepted and what we had seen back in last year. There are a few patients that actually had a chronic DVT whenever they came across, and it was very clear from the updated scan as well as historical scanning, that there was no recanalization, or the description of the so-called new event read the same as the historical event. And so ultimately, chronic DVT, and trying to define the difference of it with actually post-thrombotic syndrome. The leg became more painful, became more swollen, but actually the clot burden was unchanged, and more often than not, D-dimer is usually negative. But and again, to keep the patients going and to ensure that they have adequate education, we take them across. But you can see the three largest spikes that we have through the clinic are for DVT, pulmonary embolism, and thrombophlebitis. So the way that it's currently set is that at the 3-month review stage, we will go down as in the hematology team, and we go down to the clinic and then we review the patients at 3 months for those within whom ongoing anticoagulation may be considered. So that's predominantly the proximal DVTs as well as the pulmonary emboli. All patients are discussed with the consultant of the week in coagulation. On a Thursday morning, we will go through all scans and all blood tests to determine if anything extra needs to be done or investigated with the patient. So it's a very close communication, very close overview with the medical and the nursing team. If we take the DVT and take it by breakdown, then what we can see, surprisingly, the majority of the cases are of a left proximal DVT, followed by the right proximal, and then we have the lower limbs. Not all patients with lower limb or below knee will be anticoagulated, but again, it's very difficult without actually seeing a patient and assessing them as to what way it would go. Upper limb is not hugely common currently. I think the majority of upper limb clots tend to be more the unwell patients, they are inpatients, and there's a small proportion of patients who had a bilateral lower limb clot. So I think probably a lot of this should resonate and reflect a lot of your own particular practice whenever you look at it. So these are the ambulatory so-called well patients who have had a clot and managed predominantly as an outpatient. So at the outset, whenever I had reflected or talked on data, one of the things that I've been doing for quite a time has been collating CTPA data. So that's to say patients who have been scanned by CTPA and who are reported as positive. So the chart themselves will go back to 2012, whenever there's a little bit more of a comprehensive data to go back to look forward from. So your graph on the left, if we look at the blue line, so this is the total number of CTPAs that have been undertaken in the trust going back over that 10-year period, which has largely been flat. However, as you would expect, and as you can see, that in 2021 and last year, there was an exponential jump of almost doubling of the number of CTPAs that were undertaken across all the sites. It goes without saying, it's very clear that the COVID impact with regards to patients and inpatients as well as ventilated patients, clearly the CTPA became a fairly standard and common investigation. Interestingly though, even though it was undertaken twice-fold, the incidence of positive results doesn't necessarily reflect that, in that yes, they did increase, but not to the same volume of what the scans were undertaken. So around about 10%, depending on the years, between 9 to 13% as a trust that we have seen a positive rate by the CTPA. The graph to the right then will take down the 4 main sites for the patients at the City Hospital, the Royal, the Mater Hospital, and then Musgrave Park Hospital. As you look at it, what's important to remember is always that patient flow and decisions where patients are placed and where services are placed very much change. So whilst we might look at the Mater Hospital at the grey line and think that something has drastically gone wrong with our ability in tailoring their incidence of pulmonary emboli, it's important to bear in mind that in 2021, the Mater Hospital was deemed the COVID hospital for the Belfast Trust. Therefore, all patients with known or suspected COVID, or those within whom an ambulance was called to bring somebody in with breathing difficulties, they were all preferentially admitted at the Mater site. So that will account for the very large spike there, as to with the Royal Victoria Hospital with the orange line, as it was our regional intensive care unit. Blue line City Hospital looks amazing, not just because that's where we work or where we're based, but in 2012 we did have an emergency department, we did have an acute medical take and an acute surgical take. And by 2022, the hospital is largely haematology with regional bone marrow transplant, nephrology with renal transplant, and oncology. And just within the last 6 months to a year, elective cancer-related surgery has returned to our site, and we don't have an emergency department. So most patients in Belfast through the medical take will present to Royal to be admitted with their pulmonary emboli. So that will account for that. The yellow line then is Musgrave Park, which is our elective orthopaedic site. So what you can see, particularly with regards to 2021, the impact of surgery and the downturn in elective orthopaedic surgery is clearly highlighted with the drop in the incidence, the significant drop in incidence of PE during that time. So you can see that decisions made with regards to hospital services can be often mirrored through PE and where patients are placed and where they may be diagnosed. Under hospital acquired thrombosis, then, we know that this is perhaps one of the areas that perhaps prevention is more commonly applied to. We know that it cannot be a never event. So even with all of the maneuvers that we have currently in place with regards to medicine, with regards to compression and hydration and mobilization, it is simply not possible to make hospital acquired thrombosis a never event. We should be able to reduce down its incidence, which is often quoted as anywhere up to 60% of all episodes of VTE. So one of the things with the historical data that we did have was really asking ourselves as a trust and with risk assessment, what is the actual incidence as best as what we can determine it? And that's often difficult, particularly whenever most of your surgical specialties are regional specialties. So if a patient may travel to Belfast for a procedure, but they may come from a different health trust, how are we assured that we capture that admission in a different trust? And that's been a very difficult thing for us to try to accurately work our way through. And so at best, what we have been able to do is to look at us diagnosing VTE. So it's kind of as a marker that we would expect it to be slightly more than what we're currently able to measure. So we've taken the 50-60% through NHS England report, all the way back in 2013, as a benchmark to see how we currently perform against it. So I had a colleague who had gone back through 2019, 18, 17 and 16, and unlike my previous graphs, which looked only at CTPA, what Chris had done was had looked at all PE incorporating BQ. So we got the scan codes from radiology, and we physically went through each code and marked up the number of positive scans as diagnosed. So all PE by CTPA and by VQ, DVT lower limb, DVT upper limb by Doppler. So the total amount then was done, and then each positive episode was then interrogated using the 90-day banner that defines hospital-acquired thrombosis. As we can see then, whenever we looked at the totals as diagnosed, that an incidence of hospital-acquired thrombosis as a total of those diagnosed was around 40%. Remembering that a proportion of that, the 9%, is the defined outpatient managed cohort. So there's a bit of a disconnect with regards to inpatient versus outpatients, but if the incidence is accepted to be 60 or 50 to 60%, then can we take this win of 40%? It seems to have plateaued out. And we had 2 medical students last year on a secondment within our unit. And then we asked them to update the figures with a specific interest really towards COVID-associated pulmonary emboli, just to see where we were at, because there was a little bit of logic that we had kind of thought that perhaps given the downturn in elective surgery and the association that we are aware of elective surgery, surely the hospital-acquired thrombosis definition by admission should actually be down. Now, a little bit surprised, perhaps naively so, but the incidence, as had been observed then in 2021, had been at, again, around that 43%, as you can see. And interestingly, though, with regards to COVID, that of all of the patients who were diagnosed with pulmonary embolism in 2021, around 1 in 3 of them had COVID mentioned on their scan as the reason behind their admission to hospital. So hospitalized COVID patients, those who were patients diagnosed with PE, a third of them were hospitalized COVID patients, both from the intensive care position, but also from a medical ward position. So is 40% as good as what we can get? And I think that's just something that we hope to take forward. So when we think about hospital-acquired thrombosis, then what we wanted to do with the original work that we had done is, well, where are they predominantly coming from, and what is it possible to do about them? So whenever we had gone through the original group of those 3-4 years, then it was fairly clear that there was a small clustering predominantly with regards to elective orthopedic work, as well as patients with a background history of cancer. As you can see from the rest of the tables throughout the trust, there's a general low-level spread of other sites, but the specific ones that particularly stood out were within that area. If I go back to the CTPA data and look particularly over to the left, so this is looking at the blue line being the total number of scans done at our elective orthopedic site, and then the orange level being of those who were positive. So unlike the rest of the hospitals, there was an approximate 20 to 24% positive rate with regards to a PE diagnosis through CTPA within this hospital in 2012. And whenever we looked at it, it's fairly consistent with regards to a team that were a little bit more skewed. Now, that was very difficult to say, was it the team, or given the fact that they were doing the vast majority of the work, that perhaps by chance alone it was going to be there. But we did have a discussion, and around about this stage, the risk assessment was placed into the regional drug cardex. So within Northern Ireland, we have one medicines inpatient cardex for the whole region. And whenever you open up the inside left-hand sheet is the national VTE risk assessment. So whenever that was getting incorporated into it, there were a lot of meetings across sites and a lot of discussions, and some concern raised about bleeding risk. Therefore, some sites, such as Musgrave, that we encouraged it to be completed at the end of surgery, so that it was very clear how the surgery went and how hemostasis was, or how bleeding was deemed at that stage. Also highlighted things like early mobilization and hydration. Reinforced the fact that we were not saying that everybody required chemical prophylaxis. Therefore, actually, I suspect that what we had seen was a slight change in some pattern, hence why the prescribing or the provision of the low molecular heparins haven't changed significantly. But ultimately, what we did find then, whenever we looked at CTPA again the next year, chance alone, I perfectly appreciate all of the arguments 2 and 4 as a nice success, and showed that there was a 2/3 reduction with regards to PEs as diagnosed by CTPA. And during that time, the work across the whole trust consistently showed that this site was 100% in their inpatient documented completion of the VTE risk assessment also. As a slight aside, whenever you get a lot of data, you do like to play around with it. And we often kind of feel that sometimes we have quiet weeks in the VTE service. Then other times it's like, gosh, where have all these people come from? And there have been some publications in the past with regards to VTE incidents with regards to seasonal variations. So more recently, predominantly for the ISTH coming up, we had looked at our seasonal variation, taking all of our PE diagnoses history. And again, as has been considered in the past, that there are summer and winter spikes. And you can see that there's a slight, definitely yellow always trumps the rest of the colored bars. So that's winter, going back for the last 6-8 years, as well as an additional spike, usually in orange. And it's interesting to see that it's still held true, even with COVID. If we look at some of the examples of our inpatient risk assessment, so this is our VTE nursing team physically going and doing it. Sometimes we get asked, well, why is that necessary? Why can wards not do it themselves? Well, I think that you probably will all appreciate the fact that self audit and review, whilst very worthy, and the rigor of an external completing it is there. And so this has allowed us over quite a protracted period of time to highlight specific wards and specific trends and challenges. And we can see through the 4 major sites, and the compliance by month of patients is generally consistently greater than 90%. And we would have a target or a preference to push it to 95. So as an example, 2021, last year, a little bit more difficult for the team to get out and about and to go on to all of the wards during the pandemic. So the last complete year of data that we currently have is 2021. And so we can see that there's thankfully a very large gap between 0% up to 80. And for the trust overall being pale blue with the target set at 90, for the vast majority of the time, the individual sites and wards are the correct side of that. So monthly data is physically collected, and I think that presence just keeps VTE front and center with our ward managers and teams. It does allow direct feedback to the ward, but also all the data is collated by ward itself and is sent back and then disseminated and shared. There is a regional risk assessment leaflet that all inpatients are encouraged to get, and allows us to do that as part of the audit, just to check with the patient, did they get it? And if they don't, we always take a stack of leaflets with us. And ultimately what we'd like to do, and have been doing now for the last few months, is just starting to collect data for all PEs through BQ, CTPA, as well as Doppler scans, and then finding the hospital-acquired thrombosis and commencing the root cause analysis tool with that. So we have support from our senior management team to take the root cause analysis tool and send that out to the audit leads for each of the specialty sites for them to complete it. Happy to assist them, but I think what's important is that they complete it, not us. And that's where the learning is, and then to return that and then to collate that going forward. See if we can, again, try to drive down, if possible, the approximate 40% hospital-acquired rate. Sometimes, though, whenever we measure this, we often get asked the question, what's the point? You know, why do you have to have a documented rate of above 90%? Why do you want it 95%? So we go back to the original data that we'd done with regards to hospital-acquired thrombosis, and we had plotted the two on a graph with a line of best fit. And rather handily, if ironically, or indeed thankfully, the line of best fit with regards to the hospital-acquired thrombosis incidence continue to have a downward trend as the monthly VTE risk assessment completion had its upward trend from 90 to just over 95%. So I think to see whether or not the hospital-acquired rate plateaus, or can we continue to squeeze a bit of it out? I'm not sure, and perhaps as a wider grip, maybe a project to take forward for more than just one centre. Cancer-associated risk reduction is a very challenging one, because the disease itself is something that we know that drives the thrombotic risk. What we have tried to do with regards to it on the wards and through their education, we know the NICE guidance has recently, through its recent update, has advocated oral anticoagulant choice of the DOACs versus the low molecular weight heparin for patients who are newly diagnosed with regards to their pulmonary embolism or their DVT, dependent on their cancer site and renal function and everything that you know. More commonly, however, is there's many more patients with cancer who are managed as an outpatient through chemotherapy than are managed actually as an inpatient. So one of the things is discussions with some of the site-specific teams, and Gynae being one that's very keen on this, has been the consideration of VTE prophylaxis for the ambulatory patient. It's largely revolved around considering such things as the Karana score to see, can you predict patients up front within whom you might want to consider anticoagulant prophylaxis, and in doing so, then which oral anticoagulant may be more suited. So that's an interesting project that continues. And then one of the more commoner challenges that we get is the inpatient risk assessment is quite fluctuant with regards to our cancer sites. And often a lot of the discussions that we have that get fed back through meetings is their general concern of cerebral metastases that they might not know and risk of bleeding. Often try to point out, however, if that patient were to be diagnosed with a pulmonary embolism or a DVT, I'm sure that they would have no concern with regards to giving treatment dose anticoagulation in order to treat the PE, and yet the general reluctance or concern in considering a prophylactic dose. We know there have been many papers with regards to spontaneous bleeding risks of cerebral metastases, depending on the specific malignancy, be it melanoma or renal cell carcinoma, but it is something that often will hold people back. But we can still say they can do the risk assessment, they don't need chemical prophylaxis. You can say to hydrate them, mobilize them, compression and so forth. So there are things that can still be done rather than abandoning risk assessment in its entirety. Maternity thromboses within the trust then, as Joan highlighted, we had started a combined hematology obstetric clinic quite early on in 2008. And we serve to take all women diagnosed within the trust with VTE, and we see them at our clinic. The clinic runs fortnightly, depending on the moment. We can see her fortnightly. At the start, we would have done it once a month, and now it's a little bit longer than that. Happy to take them with their new clot regionally. Occasionally, women are referred in, particularly if it's a late third trimester event, referred in because we have interventional radiology should a filter be required, and those patients are managed as inpatients. The Royal College of Obstetric guidelines for reducing the risk in pregnancy is incorporated into the maternity handheld record, and there's a 100% completion rate at booking. We're still trying to reinforce each hospital contact and each antenatal clinic review after that. And it's also completed postnatally. So all that work is standard, I'm sure, with your own site. So the future then, I think that we have measured a lot. We have made changes, and we have seen changes to our measurements to provide us with reassurance that we are on a right track. We don't feel that the service is particularly saturated at the moment. I think that we would like to certainly increase our inpatient footprint. There is a slight disconnect, and we suspect around about 30-35% of patients within the trust that don't get referred in after their diagnosis, either to the inpatient service or to the outpatient service or to our own outpatient clinic after discharge, and trying to see how we may be able to improve that, both as an anticoagulant advocate. We are in current discussions with regards to establishing a post-PE review. We have two pulmonary hypertension specialists as cardiologists who have remarked that they feel they get very few reviews or referrals to them with patients who have had PE. So we have identified a place and a time, and it's just now discussions about when we can start to do that, to put our PE patients into that type of review, so they get not just an anticoagulant review from the hematologist, but also a functional assessment with the cardiology team. And then, as I'd already mentioned, that we'll complete the root cause analysis for each of the hats by sending it out to the relevant teams going forward. Finally, whilst Joe and the team have very kindly invited me to come and to have a talk and reflect, This entire work hinges and is entirely dependent upon my VTE nursing team, who is headed up by Rosemary, along with Tracy, Wendy and Trez, for doing the entire outpatient service, view of assessments, as well as the inpatient medic Cardex. And my medical colleagues that I work alongside, Claire Corrigan and Richard Gooding and Charlene Neal. I think the ongoing support of the trust itself, it really does make a big difference to have the trust supporting and wanting data and looking at it, and going through it. And it has driven some element of an investment within the service, but largely we've taken what has already existed and simply rearranged it, as opposed to necessarily gotten a significant cash injection into the service. And then finally, of course, is the patients themselves, for their attendance, their coming into clinic, and for everything else that they have helped us to support the clinic and to be there for its changes and to give us their feedback. So, and ultimately, thank you for your attention and for your preceding lunch break. And I do hope that there's been something there of interest or ridicule for you to take forward. So thank you very much.
Thank you, Gary. That has been a tremendous journey through the development, facing change, rearrangement of staffing, pandemic, all of it. For people watching, often something we hear is when somebody's in post and they don't really have a team around them. And you sort of touched slightly upon that when you arrived at the trust. So what would be your tips, if you like, when you first there, you know what you might want to achieve, but the first low hanging fruit maybe that you start to look for to help to make that journey?
Yeah, I think as a naive consultant, I think sometimes the easier bit whenever we come into it is just trying to understand currently what pathways are available. I suppose I had a slight advantage in that I completed my haematology training here in Belfast, but then spent a year in Edinburgh, which was invaluable to me. So I think I got to see how somewhere else did it. And then in that year of Edinburgh, I started contacting Rosemary, our VTE nurse extraordinaire, and saying what she did, how she did, and the type of support. And I think sometimes people were very open really to the support. Emergency department were exceptionally open to moving the service. Their statistics and their data, patients reattending for INRs at that stage, and they didn't really feel that they were an outpatient clinic, and so they really wanted to diagnose the patient and then to move them on. And so they worked well. So I think just sitting back, understanding what currently goes in, sometimes we can jump in and think that we know best, and sometimes we don't need to change it, we just need to work alongside it, whereas other times we might need to sell ourselves a little bit. But I know that in some of my other colleagues' trusts throughout the region, that the service itself is perhaps managed more pharmacy-led or more emergency department-led or more acute medical take-led, where the patients were managed. So it doesn't necessarily always have to be haematology.
And I'm aware of time, but one more quick question really is, your HAT rates have certainly fallen and are well below what we see as the national potential average. Have you found those factors that link those current rates? Because I know in England they carried out the NHS sort of getting it right first time survey and found some key factors. Have you been able to identify any of those?
We're not, if I'm honest, particularly sure. I think that we've looked at it to try to see, well, if we don't know what the preventable rate is if you have a diagnosis of cancer, for example. So one of the options is, well, actually, if you were to exclude the cancer data and set it alone and just look at non-cancer, then actually the HAT rates are improved, even beyond the 40% that we have. I'm not sure. I think even the NICE guidance itself acknowledges the fact that it's not zero, and all we can ever do is to ensure that we do all we can to reduce that risk. But my question is that we've consistently hit this 40% ceiling, and whether or not it's ever going to be likely to be less than that. And that's where perhaps part of the challenge to the broader group is to see actually how low can we go. That instead of having an upper limit, actually, what is our lower limit target to say that, you know, we should be aiming that our HATs should be less than something. But I don't know. But yeah, it's multifactorial. It's very difficult, and there's so many different things in a patient's journey whenever you look back through a HAT episode, and ultimately all you do is you look through the last admission. And then that tends to be the event that we look forward to. But there's so much more than that goes on.
Absolutely brilliant. Thank you so much. There's so much learning, which I hope people will take away, and also tell their colleagues to come and watch in the recording, which will be available later. But for now, thank you so much.
Thank you.
Bye.